You have viewed the simulation scenario of resuscitation by Dr. Asif and team. Now it is time to debrief. NRP recommends debriefing after every resuscitation scenario. We always consider simulation is just an excuse to do debriefing. So debriefing process is entirely different from that of a feedback. Feedback is more of blaming or like pointing fingers, and the learners do not learn that well from a feedback. But debriefing process is an experiential learning of the learners. Learners actively reflect their deeds and learn from each other. Now we are going to see how the team is going to debrief.
Good morning everyone. Thanks for coming.
Good morning.
Let us debrief about the resuscitation now. Though the resuscitation went on well, it is always good to debrief so that we can discuss whether we can do anything differently in future. It was a good team effort really. We anticipated high risk delivery and prepared well in advance. However, we had tense moments during the process, but with a good and coordinated team effort, we were able to manage the situation efficiently. The team members did their assigned roles very well. This is my view. How do you all feel about this resuscitation?
I was happy to be part of the team. My role has been well explained. The instructions were explained clearly and I was able to follow.
I feel that the whole process of informing the NAC team about the probable high-risk delivery, the way the team members were assigned their roles by the team leader, were exemplary. I was called on time, which was really appreciable.
In my opinion, time management was good. My role was assigned appropriately. The way the team members were communicating with each other during resuscitation was commendable. The situation was demanding and I was engaged throughout.
Yes, I understand Dr. Dinesh, but as a team leader, I wanted myself to be involved actively in the later part of the resuscitation so that I can have a bird's eye view and have an overall control during the entire resuscitation.
Yes, I understand.
Yes, I really appreciate you that you have started positive pressure ventilation in time and we correctly identified the ineffective ventilation and taken appropriate ventilation steps, corrective steps. This is the most crucial step during neonatal resuscitation.
I have a question. Instead of doing MR SOPA in sequence as ventilation corrective steps, could we have started with increase in pressure first?
It's a valid question, Dr. Dinesh. The commonest reason for ineffective ventilation is improper sealing of mask leading to leak. In addition, unless we keep the airway open, increasing the pressure would not be helpful for ventilation. Hence the sequence. Hope I answered your question.
Thanks for enlightening. Sister Surya, overall how do you feel about communication?
In my opinion, whenever Dr. Asif was communicating, he was calling by the name. It was helpful and also we got back every time, completing the loop by verbalizing loudly.
Yes, it helped the situation in the smooth running of the resuscitation. I appreciate Dr. Shafi that you came in immediately after calling. What was running actually in your mind when we were called?
When I was called, I was sure that I had to prepare UVL access and medication as the role was assigned to me earlier. I started preparing as soon as I reached. I could have completed the communication loop by saying, I am going to prepare UVL access and medication, sir.
That's fine, sir.
Shall we reflect on how we utilize the resources?
Skills were assessed prior to resuscitation and accordingly everyone was assigned their role.
I felt calling Dr. Shafi at an appropriate time as per your instruction helped in this situation.
We used the available resources which were kept ready in anticipation of a high-risk delivery. It is always good to have ready-made charts like equipment checklist, saturation target chart and endotracheal tube charts which help in this emergency situation.
Is there anything we could do differently?
The entire scenario went on well. I could remember one thing. I did not suction the nose following the suction of the mouth. The baby was not breathing. I was thinking about the next steps of resuscitation.
I also could have reminded you.
Why can't we continue bag and mask ventilation instead of intubation before chest compression?
It's a very interesting question, Sister Surya. According to NRP guidelines, intubation is preferred before chest compression. Majority of the times, baby improves if we take care of ventilation effectively. One such means of providing effective ventilation is by intubating the baby. And also we can perform positive pressure ventilation with chest compression in a coordinated manner.
Since we had the skills and expertise, we decided to intubate and give positive pressure ventilation.
Thank you, doctor.
Before we conclude, is there anything else you would like to share?
Throughout the scenario, professionalism was maintained. As a team leader, even in the tense moment, I liked your calm and composed attitude.
I also noticed that we were monitoring each other's performance, which led to the better coordinated efforts. I feel this is important to improve the quality of patient care.
I have been working here for a while. I could reach out for Dr. Shafi through his extension number immediately. This is how knowing the environment helps us.
It's a very good learning experience for all of us, and thank you all.
Thank you.
Thank you.
In this debriefing, you can observe that the approach was non-threatening, all could express their views, all had mutual respect for each other, and they have reflected their actions. Their key behavioral aspects were also brought out by the team. This debriefing session was conducted amongst those who participated in the resuscitation. This can be done even with the facilitator. We made this particularly to insist that debriefing can be incorporated in your routine activities itself. This can be done in a simulated scenario or in reality. Best wishes from IAP NRP FGM. Thank you.